Welcome back to the Chatty Vets pod. Hopefully by now you're becoming a seasoned listener and have had a chance to listen to our previous 2-week Takedown episode, as well as our first bonus episode on head tilt in small animals.
Yes, welcome back. So today's podcast is our second 2-week Takedown podcast, where we aim to bring you up to date with all the latest news and products in the UK from the last few weeks.
We've got a good show today, Charlotte. We're covering everything from a new anti-itching medication in dogs to a new NSAID that's hitting the shelves, and a new test for IBD.
One thing I did want to talk to you about first thing, Brendan, you went to London Vet Show at the end of last year, didn't you? How was it? Any news or insights or anything to write home about?
Yeah, London Vet Show was really good. I haven't been to any of the conferences for a few years and I always seem to work shifts. That said, I started the first day and I was ready to go to every talk, get every inch of information out of it. I did have a really good talk or two. And then by day 2, my whole ethical stance on learning broke down and I just saw all my friends. I bumped into so many people, chatted to all those people. I think, is it 3 days or 2? I don't even remember now how many days I did.
I don't know. I've never actually been.
Maybe. How have you never been?
I know. I think I've just always either been working or because I'm doing my certificate at the moment, all of my CPD allowance is going on that. So I don't really want to pay for it because I'm stingy. So I'll wait till my cert's done and then make work pay for it. So
it's so cheap though. It's the best value for money one. Though there was some really good stuff on diabetes, which admittedly I didn't go to, but I heard about it. Zenrelia was big as well. They had a massive stall.
Okay.
I think that was the biggest drug promotion I could see.
Yeah, I mean, I've heard about Zenrelia, but I have to sort of admit I don't actually know that much about it. I know that one of the practices that I work at is trying to stock it now instead of Apoquel, but it's supposed to be like the new superior version of Apoquel, right? Is that supposed to be how they're marketing it?
I think that's what I'm getting. I chatted to the rep about this for quite a while. It seems to work better. The trial work, they did a study in 169 dogs in each group with Zenrelia versus Apoquel. There were 25 clinics for 4 different countries. It was a good study. I think it was something like 112 days. But basically, the graphs are really revealing because I think it fits. Well, if this is how it's going to work, but if the Apoquel graph is exactly how we experience it, where you start them on the double dose for 2 weeks, it's really good. You then drop them to the once a day dose and some of the itch comes back. Whereas when you look at the itch graph for Zenrelia, it doesn't do anything of the sort. It's once a day all the time and it just gets slightly better over months.
Okay, so there's no loading dose. You don't have to increase it. You don't have to give them like with your Apoquel, you have to buy a daily dose for 2 weeks. You don't have to do that for the Zenrelia. It's just once a day from the get-go.
Yeah, it's simpler actually, because I find that a bit annoying when I'm talking to clients, because sometimes I'll say, you can do the Apoquel twice a day now and then if you get a little itch flare up. But I always say, but the company never really explained to us exactly what now and then means. I don't know. I remember the last time I checked, which was probably 5 to 10 years ago, I couldn't get any clarity on how often you can do twice a day. And also, I think the client's always a little bit disappointed as well once you come off the twice a day and go to the once a day and some of the itch comes back.
And also for compliance, because they're like, well, it was safe enough for 2 weeks to give it twice a day, so why can't I just continue to give it twice a day long term? I think people don't really understand that it's not safe. It's not like if you were double dosing Metacam every day, people from the get-go think it's more safe. So maybe I think compliance is a bit of an issue with that. I definitely have people that have been, I've just been giving it twice a day consistently. I've thought, please don't do that. So I mean, that's quite good. But is there any sort of side effects that we know about if it potentially works better than Apoquel? Is there anything we need to be more worried about than Apoquel or not really?
So it's a different action. And I think this is why this new drug, Zenrelia, might potentially have more side effects, but it doesn't seem to be. So one of the reasons is it targets different JAK receptors and it targets the JAK2 receptor. And that's meant to be more of the housekeeping receptor that looks after red blood cells, white blood cells, and all of this. So if you inhibit that, you might therefore get more suppression of hematological parameters. So that's where it might be more negative. And when you look at the study, there is slight reductions in white blood cells, as far as I remember. But whether that's of clinical significance or not, I suspect it isn't. I think I think I got it from the study here, the authors describe it as a small change and not considered to be of clinical relevance. So Yeah, it's hitting the immune system a little bit more, but then it's working. I think from what I'm hearing, it seems to be working better. I don't know
Yeah.
if you've heard much about people using it.
No, not really. I don't know about anybody else, but it seems to be so new where I work that nobody really knows that much about it. So I think it's just trying to figure out what we need to be suggesting to clients in terms of how often we need to be checking, hematology bloods or exactly what it is that we're supposed to be checking. And is that every 6 months? Is that once a year? Is that how often are we doing it? It's just trying to figure those things out, really. But I don't know. I also think when these new drugs come out, they've brought out a new drug that is supposed to do exactly the same thing that a drug that's already on the market does. And when you already have something that works so well, I don't know, it sort of feels a bit like, why rock the boat? Why use something different? Because there's so many dogs that are on Apoquel and even sort of half dose of Apoquel and are working really, really well, in which case I probably wouldn't consider using a different drug. But then, like you say, there are those ones that they come down to once daily dosing instead of bi-daily dosing. And they get worse again. So maybe it's those ones that we need to be targeting with the new drug rather than saying, okay, well, we're just going to stop using Apoquel now and use something different. Is that kind of how you'd look at it, Brendan?
That's exactly what I'm doing. I think I say, look, I've
Yeah.
been using this Apoquel for 15 years, whatever it is. I don't really get problems with Apoquel. I love it. And I say, look, we'll go to the new drug. I just tell them about it. I say, look, there is a new drug. I think it might be a little bit better, but if this isn't working 100% and you want to try something, then let's try it. But let's try the drug we know really well. So which sounds like the same kind of approach as what you're doing, I think.
Yeah, yeah. I guess the only big thing that would change it is whether the price is going to be really different. Because for me, I guess we've got that option at the moment where you have the people that are insured or the people that have money and want to use either Apoquel or Cytopoint or maybe this new Zenrelia versus the people that don't have any money, but their dogs are super itchy. So you're like, perfect, have some steroids because they just don't have any money and there's sort of no in between. So it'd be really nice if Zenrelia was a bit cheaper and could be that in between drug for those clients that just don't have the money. Have you found that it is just as expensive if you've been selling it in practice?
Well, the rep made a big point that it was, if anything, slightly cheaper. However, when
Okay.
I've been, sometimes when price is an issue, I will go and look at the online prices with the client. And to be
Mm,
honest, it looks either similar or slightly more. But I think it really depends on the size of the dog. But no, essentially, it's a similar price.
okay,
So I
fine.
think
Yeah.
I think it's an option. Do you know we both know a nurse whose dog switched from Apoquel to Zenrelia like night and day. When she switched from Apoquel to
No
Zenrelia, the
way.
Zenrelia was
Huh.
controlling the itch so much better.
Yeah, you could kind of say that about Apoquel versus Cytopoint. I've had some dogs that are just not controlled on Apoquel, and you try them on Cytopoint, and they say it's like a dream, or sometimes it's the other way around. So I guess it's very much case by case basis, isn't it? So
Yeah, I need to do more Cytopoint because I think I did that thing that you do as a vet sometimes where you have a new drug option and you reserve it for the worst cases. So when Cytopoint came
yeah,
out, yeah, the hardest ear cases and whatever, and the Cytopoint was just hopeless. But I actually now realize that if you use it in regular patients, you can get some good results, I think. So I get clients coming to me and,
yeah.
yeah, I'm happy to pay whatever, something pounds for the Cytopoint. Yeah, it was so good.
Yeah, I really like it for older patients as well, because with that like compliance of them coming back in to keep an eye on if they're becoming really arthritic or if you're needing to check them over in general. I think that's quite nice, or sounds quite bad, but they're quite needy clients that always have loads of questions and, ones that just need a bit of hand holding through whatever's going on. They seem to really like that because it's really regular checkbacks. The one thing that would be super nice though is if we did have something else for cats, because I blooming hate having to use Depamed injections for those really itchy cats. It's just a pain in the bum. So it would be really nice if they could bring something out for cats, please.
Yeah, it's desperately needed. Yeah, I'm getting this as
Yeah.
well, actually. And I think people are much more wary of the side effects of steroids. Where I used to brush that off, nowadays people are really apprehensive about it. I've had a few cases recently, and I've been discussing whether we go atopica, cyclosporin,
Yeah. Okay.
or off-license Apoquel, which I think you might have done the odd one. I think I've seen I've
Yeah.
worked at the odd place where 2 or 3 cats are on Apoquel.
Yeah.
Yeah.
I think sometimes especially when it's a really young cat, I think it's sometimes worth considering, isn't it? Rather than subjecting them to steroids for their whole life. But I don't know. It's just such a shame that we're having to use either something that's completely not licensed, where we say we don't really know what effect it's going to have on them, but hopefully it'll be fine, or we use something that we know is going to have massive side effects. It's just such a shame. But you were saying to me when we were discussing this podcast, you were saying to me there was a really weird case of a cat that you had on Atopica, though, it's like something that would make you a bit scared. Do you remember?
Yeah. When I was a student, I heard of a case where the cat went on to atopica for allergic skin and then within a few weeks went blind. And
No way.
apparently this is not an uncommon risk because especially if they're hunters, they'll have had exposure to toxoplasmosis at some point years in the past. The
Yeah.
toxoplasmosis will have been fought back by the immune system and just held in check. You then give them the cyclosporin atopica and the immune system's inhibited and the toxoplasmosis strikes back. And in this cat, the cat went blind, permanently blind, which has basically, as especially that happened in a formative period of my career, has put me off using it in any cat with a history of hunting.
Oh, I've always seen it as quite like a harsh drug. I don't know if that's a bit of a funny way to say it, but I only seem to use it if I really need to, like in those furunculosis cases or whatever. Maybe people are using it more regularly in cats, but I don't know. That would definitely put me off a little bit. That sounds a bit scary.
Do you know, in contrast to that, when I use it in dogs, I don't think of it as a harsh, it seems really good. And they
Yeah.
go on it, the dose is obviously high at the beginning and it's so expensive, but nearly
Mm,
always when it works, you can drop the dose. I find you can drop the dose quite low and it's still working. And
okay.
I think I think I've forgotten about Atopica because we used to use it a lot more, and then Apoquel came out, and then I
Yeah.
just forgot about it. But I think it should have a place in our memory because yeah, I think it can work quite nicely, but it just got it's a delay till it kicks in.
I don't know why. I think I've just got this like weird thing in the back of my mind that it's a bit of a scary drug. I don't know where that's come from. But again, maybe it's because when I qualified, Apoquel was already out. So it was something that I've just never really had to use apart from in the anal furunculosis and German Shepherds and stuff like that. But
Yeah,
I think the thing is that all of these drugs are so expensive, aren't they? Which makes it so tricky. Like when you were saying, Atopica is ridiculously expensive to start off with, especially in those big dogs, isn't it?
yeah.
And I mean, dermatology is not my bag anyway. I don't love it by any means. But the thing that I find really tricky with these cases when you're trying to speak to someone, I don't know, you have a bulldog owner who comes in and they're saying that their dog keeps getting recurrent ear issues or you're a cocker spaniel or whatever, and you're trying to speak to them to say, you keep getting recurrent ear issues because you've got an allergic skin issue. So why don't we try some medication long term to try and sort of reduce the allergic response? And then maybe these ear infections won't keep coming back as often. But I find it really difficult to persuade people to do that in the consult room when you're saying, oh, yeah, it's going to cost you like 100 quid a month to use this medication. Is that okay? People just go, no. So I'll just deal with the ear infection when it comes up. I don't know if you find that, but I find it really difficult to persuade people when it's so much money.
A little bit, but then I suppose I'm writing prescriptions, and yeah, I think it works out. I don't
Yeah,
know,
true.
pound 50 a day. But the one I notice on my skin cases is how I always make a big point of going, this is an allergy, don't you? And do you
Yeah.
find this? But the clients always go, no, no one's ever told me it's an allergy. And I'm like,
Yeah.
yeah, the allergy leads to an overgrowth of yeast in the ears or in any like nooks and crannies, like between the toes. And the overgrowth
Yeah.
of yeast, adds to the itch and all of this. And they look at me like the first person that's ever explained that allergy is at
Yeah.
the heart. Do you have that experience?
Yeah, I think as well, it depends where you're working. Like, we're quite lucky that we seem to work in places where there's 20-minute consult times and we've got time to actually talk to clients about things like this in more detail. But I guess if you work somewhere that's 10, 15 minutes and you are back to back to back, you're just going to be like, oh, it's an itchy ear, have some meds and go, which is not wrong. You're treating the problem. But I think sometimes you don't have time to have that really big conversation because it is a big conversation and it takes a while to get clients to understand it and to get on board with what you're saying. So, and then when you have to add in doing ear cytologies and all that kind of stuff, I think ears and skin is definitely one of those things we could do better in practice. But I think often it's because one, you're restricted on time in your consults, and two, people just don't want to pay for all of the extra bits that is gold standard and all the things you should be doing.
Yeah, two of the really good vets I work with, they both do so many ear cytologies, and one of them does ear cytologies afterwards to check it's resolved, which I'm quite bad on. I nearly always do a cytology on first eardrop, but not nearly always, maybe 2/3 of the time. But then where another guy I work with, he does them after a week, and I'm not used to seeing what the cytology looks like after a week. So when I'm following up on
Yeah.
his cases, it's quite interesting because I see like little damaged yeasts, that are dying off and things. And actually, the last one I did had a few little cocci bacteria in there, and I thought, oh, it's
Yeah.
not resolved, but it looked resolved. But then, like you say, it's your time, which can be really hard to manage, and the
Yeah.
cost spiraling up for something.
Yeah, for sure. I mean, I think that's always what I try and say to owners. If I have the time or the patience on that day or whatever, then ideally I always, do a cytology on day one, and then ideally 7 to 10 days later, depending on what medication I've used, I always try and repeat it, because how do you know that it's definitely gone? It's like a UTI, unless you retake that urine sample, you're never going to know. But again, it's that compliance thing, and it's the money, and it's especially if you work somewhere that's making you charge for every cytology that you run. It could be an extra 40 quid every time you do it, and for someone that can be a lot of money. So I don't know. It would be nice to be able to do it perfectly every time, but I think, let's be honest, we're never particularly perfect in every consult that we do. I don't think anyone is.
So now this kind of feeds into what you were saying about Apoquel, how much blood testing, or even the
Yeah.
cytology. So it's what is the right amount of testing? Because if you're perceived as every time the client comes in, they're feeling like they're being hammered in the wallet,
Yeah.
then you're being perceived negatively, even though you're
Yeah.
trying to balance, trying to be thorough, trying to be good with also not costing the owner too much money. It's a really hard circle to square. Is that an expression?
Yeah, it is. I think I definitely have the conversation with owners and say, like, in an ideal world, this is what I'd recommend. For my Apoquel patients, I'll say, ideally, we recheck you back every 6 months. We'll do just a routine, I don't know, like a prep profile, like a 6 slide, and a hematology, just to double check everything's okay. And I will say, in an ideal world, that would be great. I said, if you're really struggling with that, as long as clinically we're well and we're sort of doing a clinical exam at least once a year, then that's sort of my bare minimum. And then I give people the option. Then as long as you write in your notes that you've given them that option, and you'd say that's what you'd recommend, if they opt not to take it, then that's their decision. But I don't know, it's a lot of money, isn't it? And it depends. One of the places I work in Wales, blood testing's not actually that expensive. That they'll run a hematology and like a 6 slide for like 60, 70 quid, which is so cheap. Whereas a lot of the other places I'll work will be like 150. So it's hard trying to get people on board. And if you're insured and you can say the insurance will cover it because it's routine checkups for this long-term medication, then that's a different story, isn't it? But yeah, I agree. It can be hard work to keep people on track.
So did you say that for Apoquel, long-term Apoquel, you have them uses in an ideal world, you'd blood test them? Did you say every 6 months?
Well, I think that's what I might be completely wrong, but I
No,
think
you
that's what they recommend on the data sheet. But I don't know, whether I've just got that in my head in terms of any long-term medication, 6 months would be ideal. So that's what I normally say to people. But I say, oh, if you can do, even if you can do a year as a minimum, then that would be great. But I think it also depends on their age as well. Like if I've got a really old animal, then I'll be pushing for 6 months anyway, because even if it's unrelated to the medication, 6 monthly blood tests is not a bad idea anyway, if you've got an old crusty cat or whatever. So it's probably not a bad idea anyway. But yeah, I don't know. I think it's just more of a conversation to have with them, isn't it?
Yeah, that's good that you reminded me of that, because I've got into this really bad habit where it's just, I think I forgot. I think I forgot to mention about blood testing. This might be
Yeah.
why I have a better uptake on Apoquel, actually.
Yeah.
So
Yeah.
now you've reminded me, I might have to. Now I'm going to feel guilty that I haven't mentioned it. But yeah, up till now, I haven't blood tested. She's terrible, and I have picked up some bad habits actually from being a bit too laid back. Where my thyroid cats, certainly my NSAID dogs. What I do with dogs on long-term NSAIDs, I do spend a lot
Yeah.
of time putting in the notes if there's any symptoms that would suggest kidney disease, and I'm quite thorough about it. I don't go, "Oh, is your pet drinking a lot?" I'm kind of like, are you filling the water bowl up more? Are they needing an extra wee in the night? Are they weeing in the house? Are they getting you up earlier in the morning? So, and then I've got all that in my notes, and I feel like I can then justify that I have, made, and the weight's stable, the patient's appetite's good. It
Yeah.
doesn't feel like a patient with kidney disease. So that's
No.
how I kind of get around it, but still be thorough without costing the client on NSAIDs.
Yeah, and I think that's fair enough. I don't think there's anything wrong with that. You're still doing a thorough clinical exam and taking a history, aren't you? And realistically, a dog's not going to have horrendous kidneys if it's clinically completely well in itself. I mean, they might be slightly elevated, but if they're the type of client that's not going to want to afford to do routine blood tests, they're probably not the type of client that's going to want to afford a renal diet and UPC checks and all that sort of stuff. Like they're not going to want to do all those extra things that you do for kidney disease if it was really mild anyway. So I don't mean that's the wrong approach to take, for sure. Yeah.
Going back to ears and ear cytologies, and you said how, it's so hard to find the time to manage it. In my dream world, we would train the nursing staff to do the cytologies, and it would be so easy to do because they're often booking in. they book in for, we know it's going to be an ear consult or a dermatological consult, you could get the nurse to quickly take a ear sample from both ears,
Yeah.
do the ear cytology while you're doing the consult. It'll take 5 to 10 minutes, even when they come in. So they might be waiting for 5 minutes. You might even have the ear cytology results by the time they come in. So if you could coordinate it, you could make it more, you bring the cost down and make it more easy. Because I
Yeah.
do think it's something that, I don't know, is it wrong to get nurses trained and then they could take photos of what they're seeing? So you're documenting the malaesthesia or the cocci or the rods.
Yeah,
Is that
I think in an ideal world it would be perfect, but I know that generally the practices that I work at, I think it's probably the same everywhere, but the nurses are just pulled from pillar to post the whole time. So I think if we gave them another job, they might be like, "Are you joking?" And
yeah?
we're too busy. We're trying to monitor a GA and look after 4 inpatients and to clean the practice and to do our nurse consults and to answer the phones, and they're trying to do everything all at the same time. And I think if we ask them to do that as well, they might explode. But
Well, yeah.
I think, in an ideal practice, if we had the right levels of staffing, then I think, yeah, absolutely, it could be really good. And I think things like with the lab station, it's always hard to keep on top of anyway, because I don't know about you, but every time I use the microscope, there's always oil all over the 40 times lens. You can't see anything because there's so much muck on it. And you look and you're like, is that hair? Is that something that I need to be worried about? Is that sort of a bit of bacteria that was just on the microscope? Or is it actually on the side that I'm looking at? I don't know. I find it a nightmare because it's just never well looked after, is it?
Yeah, I think nurse to vet ratio is a big deal, isn't it? One
Yeah.
clinic I'm working at the moment, it's 3 vets, and it feels like maybe 4 nurses, but they're doing a little bit of reception, maybe 5, and it feels very thin for nurses. And then there's the odd place I work, it's completely the other way. But there's one corporate that I've worked at 2 of their clinics, and they seem to have a huge hierarchy of nurses from top to bottom, and nurse assistants, and they seem really well staffed on nurses. I feel like, yeah, there's a little bit of variability, but most clinics, yeah, I think we're all a bit stretched, aren't we?
Yeah, definitely. And as well as I do, in terms of the out of hours setting, it's ridiculous, the nurse to vet ratio. So it's often on a night shift, just one vet, one nurse. And I mean, I've had nights where I remember one night I was working with one of my nurses, Nikki, who's fabulous, and we were doing a biosurgery. And I think we got, I don't know, 3/4 or 2/3 of the way through it, something like that. But she had to keep popping out anyway, 1, to answer the phones, and 2, to monitor like our 3 unstable inpatients that we had. One of them was on oxygen, one of them needed loads of meds, and then somebody else turned up. I think it was a cocker spaniel that turned up collapsed with a massive abdomen. So I had to get Nikki to triage it for me. It comes in with a hemo abdomen. She was trying to scan it and half show me what was on the scanner through the theatre door. I was trying to sort of tell her how she could possibly tap it so we could work out what was going on, because they didn't have a lot of money. And I was thinking, well, if it is a hemo abdomen, she can at least get an IV in it and maybe prompt them to say, your dog's really not very well, to sort of prepare them for when I actually have a chat. Honestly, it's a nightmare sometimes. You're trying to do like 4 people's jobs in between 2 of you, but they're never going to invest into more staff overnight because there's just not the money there, is there?
I think there's a general practice and out of hours overlap here, because there's 2 clinics I work in that are newer clinics, and they're growing. So, and when you've only got a small team right at the beginning, when you open a practice or whatever, I think you're much more prone to being overloaded. You can be
Yeah.
overstaffed and then you're understaffed. If you've only got 1 vet or 2 vets, it's a nightmare to get the balance right. Whereas once you're up to 3 or 4 or 5 vets, it's much more, everything's more steady, isn't it? And if
Yeah.
someone's ill, you can take it. But I think when it's a small team, it's easy to get overloaded, isn't it?
Yeah, it's really tricky.
I was going to add into something that happened this week at work, which was a bit of an ethical thing, but it is a sidetrack. When you said about you got that hemo abdomen dog coming in and you were trying to tap it, and they didn't have much money. That reminded me, I had this case yesterday, and it was an ethical nightmare. Well, it wasn't an ethical nightmare, but it was definitely something I thought, this is interesting to work out what to do. They came in, mother and 2 adult daughters, and they had a Jack Russell. So it was 9 years old. So it wasn't that old. It's a
Yeah.
female entire,
Yeah.
slightly bigger abdomen, starting to get
Okay.
lethargic and poorly. Not much vaginal discharge at all. It had been in season about 5. Well, she said 3 weeks ago. I think it's 5 weeks ago. And obviously, obviously you're thinking, is this going to be a PIO? They actually came in, checked the urine sample, said it's drinking loads. I think it's got a urine infection. So we were all like, oh, right, okay, yeah, we can run the urine
Yeah.
test, da-di-da. And then I started talking to her and she's like, it's lethargic and it's getting poorlier and everything. So anyway, I
Yeah.
was thinking this is a PIO. They didn't say anything about money. And I started to kind of just got a slight, sixth sense that this might be an issue, because when they're completely blasé, there's the client that's so blasé, doesn't mention money at
Yeah.
all. There's actually the one that's got no
The
money.
ones that are really worried. Yeah.
Yeah, exactly. So she goes, I've only got £100 right now, which I actually borrowed from a friend, but I will be able to pay the rest next week when I get paid.
Yeah. The
I thought,
typical
this
line.
does not sound great. So then I thought, okay, I've got a possible closed PIO, but I've got a client with £100 and the dog's 9, but a Jack Russell. So, it could have another 7 years there.
Yeah.
And I thought I'd really need to do a scan to check if this is a PIO, but the cost of
Mm.
the scan is more than the £100, the consults, whatever,
Yeah.
nearly 60. So how do I handle, but then putting the dog to sleep, which I suppose is strictly speaking what you should do, feels wrong when you
Yeah.
haven't confirmed it's a PIO.
Yeah.
So, always with these, I went out, chatted to the nurses, and I think we decided it was okay to do a ultrasound free of charge, because if it was a
Yeah.
PIO, we could then euthanize it if needed. Yeah, so it was. I don't know if that is an ethical thing now I say, or is that just the obvious thing to do? But
Yeah, I think it's really tricky, isn't it? It's like those typical ones that come in overnight and you've got a dog that needs a C-section and it's like a 2-year-old dog and it's otherwise completely well, but you're like, well, the puppies need to come out or it's going to die. And it's that horrible thing of, realistically, in truth, your options are where you either pay for it or you put them to sleep. But it's just that horrible call to make, isn't it? It's just with those ones that where you just know they don't have the money, but they're otherwise a dog that could do really well if they were to just go ahead with that bit of surgery. It's so frustrating, those cases, isn't it? It's really, really annoying. They're just really horrible cases to handle, aren't they, for everyone involved, for the client, for you, for the dog. It's just horrible, isn't it?
yeah, but you're never going to euthanize them, are you? I mean, I've never euthanized a C-section, but you're always going to treat them, aren't you? It just sounds too
Yeah.
awful.
Yeah, I think, to be fair, that I've never put one to sleep, but there have been a couple where, because I've been working at like an expensive out of hours service, there have been a couple where the owners have been like, it sounds awful, but they said it was an accidental mating. We're not worried about the puppies. We just want our dog to be okay. So there are a few where I've thought, well, I can't do a C-section that's supposed to be costing £3,500 for £100. I'm going to get absolutely rodded if I do that. Whereas, I have done the odd one where I've said, look, I'm going to sacrifice the puppies, but I could give your dog some methadone and tell you to wait until the morning and then go to somewhere that's going to be a hell of a lot cheaper, which might do you, a payment plan for whatever you're going to do. I don't know. I have done that before, which feels blooming horrible, but it feels like the best compromise. I don't know. They're just those awful cases where you do, in theory, the right thing in terms of what the business would see is the right thing to do. And it makes you feel absolutely awful, like you've done what you shouldn't do against what was right for the dog. But then equally, if you go ahead and do what you feel is right for the dog, then you get absolutely bollocked by where you work because you've racked up like a £3,000 debt that they're never going to pay off. So I don't know. They're really horrible cases, aren't they?
Well, it worked out well. I scanned the dog. It had a massive closed PIO, and we euthanized. And I thought,
Yeah.
and I can't remember. I think I put the charge for the ultrasound on there, and I just said, I don't know. I think, well, she said she's going to pay it next week. I mean, I don't think it matters, but
Yeah. I mean, I always think with an ultrasound charge as well, like, has it really actually cost the practice any money apart from the vet's time? Like, does it really actually cost anything to do that? So it's a little bit of electricity, isn't it? It's not like it costs a lot of money.
what was I going to say? I had a very similar thing with the ultrasound machine as well. It's a funny, busy week actually. And I had a guinea pig with mild hematuria, and I was dying to put the ultrasound probe on it just to see if it bladder stones. And I thought, oh, I could just walk past it with my guinea pig in my arm. No one will know. Just brush the probe onto the guinea pig. Quickly have a look.
Silent
Yeah,
ultrasound. Yeah.
silent
Nothing's
ultrasound. And
happening.
it was going through my head actually. I even started to plan it a little bit, and I thought it's only a guinea pig
Yeah.
size. But
Yeah.
then I thought, no, I can't do it because we've got to pay for our equipment. And I worked in a clinic where we couldn't afford any good equipment. So I get it. We've got to raise the revenue to pay for all the nice kit.
Yeah. I do get that. But then I think I've definitely been like, I slipped and the ultrasound probe fell on that abdomen. when when if you know that you've got a hemo abdomen, but the owners are just a bit like, well, I'm not going to put it to sleep without knowing. And I just think, do you know what? It takes 2 seconds to be like, yeah, it's a belly full of fluid, to make them make the right decision for that dog if they've got no money. I don't know. Maybe that's really bad, and probably no one will ever employ me again. But hey ho.
Charlotte, are you starting to get worried that your bosses are going to listen to what we're saying and they're going to be like coming up to us and going, "Did you do a scam without taking any payment the other day?"
No, it'll be all right. I don't do it very often. It's always the ones that have no money anyway. So you think, well, even if you charge it, they're never going to pay the full bill anyway. So it's sometimes it's easier to just not charge it. I'm going to stop now because I am going to get myself really told off.
Yeah,
But
you might be softer than me actually, because I did charge that ultrasound, just for the record, if anyone's listening. So I did charge it. I
he didn't
did.
really. He's just saying he did, so he didn't
No,
get told off.
I did. Add this bit in. No, just delete everything.
Yeah.
Don't let this go out.
Right. Anyway,
Okay,
we've
come
gone
on
off
then.
to a
Next
massive
bit.
tangent. I
Yeah,
think we probably need to go back onto the medical updates we were going to speak about. So I
yeah.
know we're gonna go on to talk about new NSAIDs on the market in a bit. But before we get there, I don't know about you, but the whole of last year, one of the big things that I was thinking about in the back of my mind is the Librela debate. And should we still be using it? Should we not be using it? Which patients should we be using it for? Do you still use it on your OA patients? How do you feel about it?
Yeah, I use it a lot. And yeah, it did kind of rock our world, didn't it, when that all started coming out? Was it summertime?
Yeah. Yeah.
And I suddenly felt this incredible sense of guilt that I had started all these dogs on Librela the preceding period of time, kind of essentially just saying, well, that's fine. There's no problems at all. And then this came out, and I suddenly thought, oh my God, am I going to get into trouble? Because I've just been I've been mis-selling this drug, because now
Mm,
all these orthopedic specialists are saying it can cause rapidly progressive osteoarthritis, really exacerbate the joint disease. But then I slowly, over the last few months, I have changed probably how I go about things, because now I say that the experience of Librela in the old patient that's struggling is really positive. I don't hear negative comments very often at all. And I hear
yeah.
lots of positive comments, and I think it's worth it. If I had a younger or medium aged dog, because of that study in the summer, I would be really. At the moment, I'm not really starting them on Librela in that context, unless there's
Yeah.
some real mitigating
Yeah.
circumstance.
Yeah. I think I feel the same about it. Like that seems to be the way that it's changed how I use it. So before this all came out, I would say to people, I wouldn't go on long-term meloxicam or an NSAID long-term if they're really young, because you don't want to risk gastric ulcers and kidneys and all that sort of stuff. So why don't we try Librela? It's got very few side effects that we know of. When you're comparing it to these other drugs, maybe it's the best thing to start younger dogs on. And that's how I was using it. I was using it as sort of a first line and then adding in your other stuff later down the line. Obviously, now that these reports have come out, I've now changed that slightly. So I'm now using it as sort of a adjunctive medication on top of other stuff rather than using it as a sole treatment anymore, especially in those young dogs. But I agree, like it works so well in terms of comfort, and especially for those older dogs where their life is going to be limited because of how uncomfortable they are. I definitely have that conversation with owners where I'm like, look, quality is better over quantity. If you give them another year of lots of comfort rather than another 3 years of discomfort, then surely that's better. I do kind of think it was all a little bit blown out of proportion. Every drug that we use is going to have side effects. And when you compare it to meloxicam, for example, after you've seen a few perforated gastric ulcers that lead to septic peritonitis, I don't think Librela actually sounds that bad. But I think the figure said something like Librela was 9 times more likely to cause musculoskeletal adverse events than meloxicam. But the studies were a bit funny as well, because there was only 19 cases in that study. And then there's other studies that say that patients on Librela are far less likely to have side effects compared to dogs being treated with NSAIDs. I don't know, where do we stand? Is it really that bad?
Yeah, well, they were looking at a population of dogs that was not your typical dog, in that they were younger dogs, presumably to middle-aged dogs, because they're being referred to see an orthopedic specialist. I think that's immediately a different population to what we're seeing in general practice. And then the other thing that's going on is, wasn't it something like they were kind of self-reporting negative outcomes after being asked, are you getting anything negative? I didn't seem to be, oh, here's a blind study where we take 100 dogs on Librela and 100 dogs on NSAIDs and compare the outcome, where it didn't feel like we have got the right information yet. We need that comparative study.
Yeah. And I
Yeah.
think as well, it's made more difficult as well because a lot of the dogs that are on Librela also want a cocktail of loads of other drugs. Like, how many dogs do you know that are literally only on Librela and nothing else? Like, they're always on, nearly always on an NSAID and then Pardel and gabapentin and all of these extra stuff as well, which is great. You know, it's multimodal analgesia. It's what we should be doing. But then how do you 100% know for sure that it is just the Librela that's causing the issue? How can you say that for definite? How can you say it's not a combination of all the other drugs, or that because you've not got the same dog without any of those medications at the same age that you can compare it to? How can you categorically say that that dog wouldn't have developed those issues in its joints? I don't know. It's a really fine line, isn't it? I think I just try and make all of my clients really aware that it's now known not to be a benign drug. It's something that we do have to be wary of. But ultimately, I don't want to see those old patients just in discomfort for the rest of their life. So I do still use it, but I'm just a little bit more careful about how I word it now, not saying like, oh yeah, it has no side effects, just go for it.
Yeah, I mean, the only thing that caught my eye was they seem to be saying that this is a completely new side effect, this RPOA, the rapidly progressive osteoarthritis. It was something distinctly different than anything they've seen in dogs before. And I feel like it's been noted in humans that there's increased damage to the joint when human patients are on this type of drug, I think,
Okay.
if I've got that right. So yeah, so it did feel like something very new. But yeah, so I think where we've both ended up is probably similar, isn't it? It's the older patient. We're
Yeah.
a bit more cautious now. And it kind of
Yeah,
did you
for
make?
sure.
I made a mental note to myself. Don't ever say that in the future with any new drug, because I think I got caught up in the excitement. I was like, yeah, you've got this new drug. It's fine.
It's
Just
amazing.
throw
Yeah.
it around at everything. So,
Anyway, right, moving on. I think maybe were we going to speak about that new NSAID next?
okay, right. It's the new NSAID. Daxocox. What a stupid name. Sorry. Is that really what it's called? Daxocox. Okay,
Yeah.
Daxocox, whatever. I've never used it, but this is a weekly NSAID. So
Yeah, it's
I don't know.
weird, hey?
What do you make of that?
Yeah, I mean, I think the principle is quite good. Like, it's supposed to be highly COX-2 selective. It only needs to be given once a week. So maybe compliance is better. But then maybe that also throws out routine. Like, I think if you get in a habit of giving something once a day, you know you have to give it every day. Whereas if you say, oh, I've got to give this every Monday, is that going to be more difficult to remember? I don't know. And apparently it's completely out of the system when the next dose is due. So build up is unlikely. So maybe it sounds good in principle, but I don't know. I'm not 100% sold, but
I have noticed, I sound like an old person now, but people come in now and they seem to struggle to give a medicine every day. Why is that so difficult? I don't know. I just find it kind of, and then I've had the clients come to me and go, "Oh no, I want the cytopoint injection because I can't do a tablet every day." But I suppose I've just always had greedy dogs. I suppose is to be fair. But isn't anyone with an ECC kind of background going to be terrified of the idea of an NSAID that lasts for a week? Because if you give
yeah,
your NSAID on Saturdays and the dog gets hemorrhagic diarrhea on Tuesday, isn't that really worrying?
yeah, because it's still going to be working for a week, and how do you stop it? Yeah,
Yeah, I mean, I think certainly in my caseload, seeing dogs on NSAIDs go hypotensive from some awful trauma or illness, if the NSAID's on board, I genuinely feel that, to me, I've seen renal failure and death in several cases which I have attributed to the NSAID. Now, obviously, I can't prove it, but we
yeah,
know mechanistically it will happen, and I've seen increased mortality. I think they're genuinely dangerous drugs in hypotension.
yeah.
So I'm not sure I want to give one that's going to last for a week.
Yeah. I mean, I definitely am one for, even in our routine elective surgeries, I'll always give my NSAID at the end of a surgery because I'm so worried about that hypotension during surgery. But like you say, if you've got an NSAID that's been on board for a week and then you operate on that dog, how can you stop that? You're like, they're going to have it's going to have the effect on the kidneys because it's acting for the entire time that it's under. So I do find it a little bit scary. I think in principle, it could be really good. But well, if you've got a dog on, I don't know, meloxicam because of joint problems, or it's been uncomfortable for a week or something, or it's blown its cruciate or whatever, and then you're like, oh, it's got Addison's, bugger, I need to stop it. So it's really nice to be able to stop it and know that you can give it that 24, 48-hour washout period and you're fine. You can start a steroid if you need to, or you can take them off the drug really quickly. Whereas if you've given daxocox on like day one and then your day three, when you realize they're poorly, like you say, it's a blooming nightmare because you can't reverse it. So what are you supposed to do? I don't know.
You know what? Yeah, you're bringing up a really good point about this NSAID at the beginning of an op or at the end, because we're both locuming a little bit now, aren't we? And
Mm.
I'm finding it fascinating because I don't know, half the practices they will be no, we give it before because it's preoperative analgesia. Which, by the way, I've chatted to two human anaesthetists about this, and they both have looked at me like, no, that's not really a thing. But so
Really?
well, they have a very different culture there. This is in the last 10 years. I don't know if it's changed, but no, I distinctly remember talking to, because I talked to one anaesthetist and he said there's very little evidence for that. And that was about 15 something years ago. Anyway, some practices will insist you do it preemptively, the NSAID, and because of pain relief. And I find I'm sometimes saying, I'd rather give it at the end. Yeah. Are you finding the same? There's a real
No,
difference?
I don't let anybody insist.
I love it.
I'm like, well, no, sorry, it's my case. I'm not doing it like that. I think maybe I get a bit stroppy. No, I don't. That's over egging it. I don't get stroppy. Like I just say, I'm sorry, I don't like doing it like that. I'm worried about hypotension. But I think the practices that usually insist that you give it first, are not the ones that will put a blood pressure cuff on when during surgery. So they have no idea what's going on with the blood pressure anyway. So I think ultimately the people that are doing really good GA monitoring are not going to be the practices that would be funny about you giving an NSAID before you recover them. So I don't worry about it. I just give it when I want to give it because it makes sense to me. And ultimately, it's my case, it's my name on it.
And I relay that I still laugh about this conversation now. Oh, gosh, if this nurse is listening, then she can message in and have her side. But I had this exact conversation, and I said to the nurse, I said, I'd rather give it at the end just in case you get hypertension. I said, surely, do you ever get hypertension in the anaesthetics? And she said, no, we've never had any. And she did it with a straight face, just looked me in the eye and said, no, we've never had any. And I thought, okay, then you better just give it then, I suppose. So, she's never had a hypertension. So, yeah, there you go. What
Mm,
can you say to that? I was floored. I was like, well, okay, fine. If you never had a hypotension, then I guess on my
yeah,
case is.
I think I'd be saying, have you never had one or have you just never looked for one?
But that said, I think we probably are a little bit hysterical because, when you get a critical case and it's a bit hypotensive for an hour or three or whatever it is, it's not suddenly going into kidney. Well, it is probably increased risk for other reasons, but it's not suddenly going to go into kidney failure. But I think there is some tolerance, and a lot of GP ops are quite quick. Let's say, I don't know, it's a cat
Yeah,
spay or whatever. I do wonder, I probably think we get a bit over anxious about a few minutes of hypertension because I think the body has
yeah,
got, and also I think our blood pressure monitoring devices are awful in that,
yeah.
I have the nurse saying to me, oh, it's hypotensive. What we're going to do, we're going to give it, and we give it a bolus of fluids or whatever. But then 5 to 10 minutes later, the reading, we haven't done anything and the reading's suddenly gone back to normal.
I just think, like, why make something more risky? Giving Metacam subcut at the beginning of an op is not going to give it such significant pain relief that it's going to make the op so much better. If you're that worried, give the Metacam at the end and give it a tiny bit of ketamine during the op to make its analgesia better. Like, that IV will work, but subcut Metacam is not going to make your anesthetic that much nicer. I think I'd be asking, what's your evidence to say that you don't want me to do it that way? But maybe I'm just a bit more stroppy.
Can, we need to get an anesthesia nerd to message in for this because I'm
Yes.
right now I'm thinking preemptive analgesia. Do NSAIDs reduce the wind up of pain? Do they act spinally?
Well, if anyone has any evidence, please message in. That would be great. Tell us either way. And if we're wrong, then we'll hang our hats up.
I think
But,
evidence is a bit much to ask for because we don't have
well,
evidence for anything, do we? It's terrible what we do. But yeah,
anyway, we sidetracked again. I feel like maybe one more thing we want to mention before we start wrapping up. So we've done new drugs and stuff that we want to talk about, but there was one extra test that you wanted to speak about, like a new diagnostic patient side test or something that you wanted to mention today.
yes, I've not used it, but I talked to the lady at the London Vet Show on the stand for calprotectin. The product, I'm reaching for my notes here. What's the drug? What's the test called? Can we Google this? No, we can't talk about a test and not say what it's called. Hold on, give me a second. Dun dun dun. Pooch and Mutt are. I'm just Googling this, and Pooch and Mutt are doing a gut health test. It's the first thing
What?
that comes up.
Oh.
I don't think we've covered this in our podcast yet, but Do you know I send loads of people who don't do any worming to send poo to wormcount.com? But anyway,
No.
basically every day, about 5 times a day, if people don't do worming or they don't want to do worming or whatever, I say, oh yeah, that's fine. I say, just send a poo off to wormcount.com now and then. It's £32.50 or something like that. And
Yeah.
especially if I'm working in a lungworm endemic area, and I say, it'll give you the reassurance that there aren't any worms. So at least the ball's in their court. Because I'll usually look on the history and see they've got like 3 years of not getting a vet wormer. But yeah, one of my clients said that Pooch and Mutt do worm tests, but I don't know if she's right. But
Oh.
anyway, GI Quest is a new patient-side fecal calprotectin lateral flow test for assessing gastrointestinal inflammation in dogs and cats. Yeah, this is it. So you get a little box of however many tests. It's one of these, and it's got a long shelf life. The lady told me she was really good. So this calprotectin is a big deal. It's been going around for years, so it's about time we've got an in-clinic test. Because I think one of my friends did a master's and looked at zoo animals and was checking their calprotectin levels to assess their gut health. And I thought, oh, that sounds like a useful test for us to have. Yeah, so now we've got a test. Because, our routine biochemistry is just awful for guts. Because we have a test that tells you if the pancreas is inflamed. So then every dog that we see, or cat or whatever, they've all got pancreatitis because the PLI's up when they might not, or it might be secondary. We need a marker for gut health.
Yeah,
And
we
we've got
do.
B12
Yeah.
and folate, but it adds a huge amount of cost on. And it's okay. It's a good test, but it's a delay to get the results back. And it's not the most sensitive test. I think they're specific when they're low, but they're not sensitive. So that, not every bowel case is going to have low B12 or folate. So I think there could be a role for this fecal calprotectin test.
Yeah, for sure. I mean, what does it show? Like, if it's positive, what does that mean? Does it mean that there's just inflammation of the gut? Does it mean it's got IBD? Like, what does it mean when that marker is elevated?
Okay. So can you bear in mind this? And I'm trying to remember my conversation from 2 months ago with the rep. So calprotectin is a protein that comes out in neutrophils, and it goes out into the poo. So any inflammation with neutrophils in the gut, that will release calprotectin into the poo. The test is a lateral flow test, and you just get a bit of poo, you stick it into the little, you have these things run nowadays, and you'll get I think it's a color change to tell you, and I think it's kind of quantified as well, and it'll tell you how much calprotectin you've got, and that's an indicator of inflammation in the bowel. I believe the University of Bristol did most of the study that showed a really high sensitivity and specificity for differentiating dogs with inflammatory guts, an inflammatory enteropathy, or healthy dogs. So it seems to be a
Really?
useful test, yeah. And feeding back into what we're talking about NSAIDs. And now, look, this might be reaching a little bit, but they were mentioning on the stand that if you start a dog on NSAIDs, you could keep an eye on the fecal calprotectin, and it goes up.
Keep an eye on the gut health.
It
Huh.
goes up before the diarrhea. Because you know how in NSAIDs, often the diarrhea is on, I don't know, day 5 or something like that.
Yeah, yeah.
They said that you can pick up on it. If you do a poo test two days into the NSAIDs, it will go up faster than the symptoms will arrive. So you might be able to predict what might have yeah.
Prevent it.
I can't imagine any of us doing that, by the way. But
No.
basically,
It's an idea.
It's an idea. Yeah, exactly.
Yeah, exactly.
How am I going to get you excited about this fecal calprotectin test? I don't think I am.
Is
Am
it
I?
cheap? Because if it's cheap, then maybe it's something that could be used.
Yeah, I don't know. Is it a pack of 10? I can't quite remember. And it's got a long shelf life. So is it cheap? I don't think it's expensive. No.
Yeah.
And yeah, look, I can see your apprehension, because you could argue that if you do a food trial and you see your fecal calprotectin level go down, then that's great. You've really shown that the new food helps. But you could also argue that the dog going from having soft, wet poos to having firm, solid poos is also evidence the gut's better.
Exactly.
Yeah, okay. But how about cats though, where they can have lots of gut disease and they might be losing weight from their gut disease, but their poos are still solid? Maybe fecal calprotectin could be useful there. Maybe.
Yeah, I think it sounds like it's definitely got a place. I think it maybe just we need to be educated on it more, don't we? Like, have those lunch and learns with the reps coming around and saying these are the cases that it would be really beneficial for. But I think it's something that could be used for sure. We just need to work
Yeah.
out when.
We need to interview that nice lady on the podcast
Yeah, maybe we should.
from GI
Try and
Quest.
find her. Try and find her.
Yes.
Did you save her number?
I don't know. The problem is, me and her are going to be really interested by this, and then is everyone else going to be like you?
What, not interested at all? Can be
Yeah.
like, no.
We'll be chatting on for half
I'm
an
not
hour. We'll
gonna
do it
use
as
that.
a bonus episode, or this will be the episode that no one wants to listen to episode.
If you're interested, yeah.
Yeah. Special members, fecal interest society. Yeah. So
Yeah. Oh
yeah.
dear.
Okay. Well, there you go. I
Right, anyway.
tried to sell it. I failed, didn't I? Oh
Yeah.
well.
But no, it sounds kind of good. Okay,
Yeah.
well, maybe we should get towards rounding up. But I did think, we end up talking about so many negative things that maybe just before we rounded up, there was one really, really positive case that I had fairly recently that I thought maybe I'd just mention. I had a case, an IMHA case, come in just before Christmas. And she was really, really sick, typical Cocker Spaniel. But she had already had a blood transfusion when she came into me in out of hours. And her PCV, I think, was like 16% post-transfusion. So it was not great, but okay. But she was steady overnight. I ended up sending her home the next morning. She was already on steroids, blah, blah, blah. Finished work that morning, went back into work that night. The guy called me again and he was like, something's wrong. She's got really lethargic again. She's really not well. He came back in and her PCV had plummeted to like 9 or 10% again. And their insurance had run out. And I thought, oh God, she's at the point of needing a second transfusion. So I had that really frank conversation of saying, you need to make a decision at this point. Like, you might end up spending another few £1,000s and still this could happen again, in which case you might need to think about euthanasia. Or I can admit her, we retransfuse her and we see what happens. She might do okay. Anyway, they had a really big conversation, obviously got really upset because she was quite young. I think she was only like 13 months or something. She was really young. And anyway, they went for it. I readmitted her. I got some blood, transfused her. PCV came up. Can't remember what to, but it came up. She was doing okay. I added in a second immunosuppressant drug as well, just to try and hit her with everything. And she went home and she's doing fine. So I just thought sometimes it's nice to mention a case that actually goes really well because we don't have many of them that often. So sometimes it feels like it's worth it.
When I'm hearing about that case, it reminds me how different my life is now the last year, because I haven't done nearly no out of hours emergency work at all.
Yeah.
Yeah.
But then you get more of the fluffy, nice stuff like puppies and things like that, whereas everything just dies in out of hours. So maybe it's
on the cheery subject of death, I had a really nice situation with rabbits and guinea pigs. When they lose their little mate, I sometimes say, "Oh, go and get a teddy bear that looks a bit like them to keep them company." You don't get any of the issues.
Does that work?
Yes, it really does work. And I've been saying this for 20 plus years because years and years ago, when I was beginning of my career, we had a rabbit in the hospital and she said he must be with his teddy because he loves it so much. We got the teddy after his friend passed away. And whenever I think the rabbit was in hospital for a while because whenever we took the teddy bear out, he would start like pounding at the thing and getting really upset. So we had to have the teddy with him. So ever since then, I've said, if we're putting to sleep little, whatever guinea pigs and rabbits are called, I don't know, whatever, little fluffy, then you say, oh, why don't you get a teddy bear that looks a bit like... Anyway, someone came in this week and she had a little... Because I've always thought it must be really hard to get a teddy bear that looks like a guinea pig.
Yeah.
Right, this is where this conversation is going. So she had a little puppy teddy bear, but it was brown. It was like a guinea pig colours. It was like brown and stuff. And it was exactly the size of a guinea pig. And it And it worked as a friend for the guinea pig.
No
and I
way.
thought, there you are. So, because I've always had this worry they won't be able to find a guinea pig teddy bear. They can just use a puppy teddy bear that's the same size as a guinea pig. So this information, get it out there.
There we go. Breaking news. Everybody start doing that,
Yeah, I've got a photo of the teddy. I took a photo of it as well because I thought, wow, this is so cool. Guinea pigs everywhere are going to be so much happier.
We'll have to post the photo. Yeah.
It's very cute.
Okay, right. I feel like we need roundup time. So we've covered Zenrelia, staffing levels in practice, teddy bears for guinea pigs, Librela, and daxocox. I feel like we've covered quite a lot.
Yeah, so hopefully you've really enjoyed the episode. Do get in touch if you've got any comments or suggestions that you'd like to give us to improve the content for you. And also suggest any topics that you think we should cover.
Yeah, please do get in touch. We'd love for you to, or hopefully help us to improve the episodes and not talk about things that you don't find interesting. But for now, thank you for listening. Join us again in February for our first 2-week Takedown episode of the month, where we'll be covering a few topics from recent tricky cases we've seen, T-tubes and their issues, and some blood testing, and loads more. Until then, it's bye from me.
And bye from me. Take care. content presented in the Chatty Vets podcast is intended for licensed veterinary professionals and is for informational purposes only.
Views expressed are those of the host and guests and do not substitute for clinical judgment or individualized patient care.
Drug dosages, protocols, medical advice discussed should be verified against current literature and manufacturer's guidelines.
Class and its creators are not liable for any errors, omissions, or adverse outcomes resulting from the application of this information.
Always consult relevant laws, regulations, and institutional policies in your practice. Listener discretion is advised.